Thank you so much, Zuzu, for the kind introduction, and thank you to the organizers for inviting me to speak here. So as my children are not adolescent, but they've been adolescents, they are adults. So when I spoke to them and told them that I was going to present at an adolescent group, they said, ditch the black suit. I'm always wearing black. So they said, ditch the black suit and ditch the verbosity. So I'll try. But I forgot my cell phone because I was supposed to be taking selfies like an adolescent, and I'm supposed to be chewing gum, but I thought I would stop there. So yes, I hope I can operate this. So thank you very much for inviting me to speak on the insights from 40 years of research and implementation. I have no conflict of interest to declare, and because I talk more than I should, I'll start by thanking all the colleagues here who assisted me in drafting my presentation. Thank you all. But enough about the oldies. Let's talk about the adolescents and young people. So we know that the adolescent and young people, the population, the current population is the largest ever in humankind. So this is the young age group from 10 to 24 in developing countries. In sub-Saharan Africa, as you can see, though this is even as short as Dr. Gichane here, I have to stand aside. So as you can see, the red here shows sub-Saharan Africa, where the young people contribute about a third of the total population. And in South Africa, they contribute a quarter, 25%. Though this is an old map, it remains the same. And when you move to the rest of sub-Saharan Africa, you'll see that Zimbabwe included, Zambia, Malawi, you'll see that our population is to the right. We've got a youth bulb giving us a pyramid like this. So we have a remarkable number of youngsters, and I think we've heard from the Minister of Health that we have many, many adolescents. So adolescence is considered the healthiest, the most important time in life. As adolescents, they have their needs, and we have to respond to the needs. But as you can see here, adolescence comprises quite a significant amount of timeline in our lifetimes. So adolescents, they have their health needs, health problems, but we must provide health services. We must assess health risks. What are we doing as the community? Are there structural actions? Are there any health determinants that are affecting our adolescents? Why am I talking about this? Because they are responsible for the next generation. They are responsible for us to be sustained as humankind. So we know that adolescent health profiles, they vary by country, they vary by development. You'll see that there are diseases of poverty, there are injuries, there are non-communicable diseases. We've already heard about them. So, and we know that there's an epidemiological shift. There's a transition as a country or a region moves from diseases of poverty, which we'll talk about today, the infectious diseases. This one is off. The infectious diseases, undernutrition, HIV, sexual reproductive, as we go through injuries and unintentional and intentional injuries, and then we move on to NCDs and other diseases, mental disorders. So we must, as we go through this week, we must remember these profiles as we go through this week. Apologies, I think one of the mics is having challenges. So yes, remember this. So the global burden of HIV in adolescent and young people remains unacceptably high. We've done a lot, but still the HIV rates in adolescent and young people, they remain high. We know that there are about 3,600 new infections in adults every day, and we know that about 50% are in sub-Saharan Africa. And coming to the red bullets at the bottom of my slide, about a majority of these infections are in young people aged 15 to 24. That's the global statistics. A sobering thought, Dr. Gichani. This is Kenya. Kenya HIV estimates 2023. We know that in 2023, there were adults living with HIV 17,800. And out of these, we can see that about 10,000 were adolescent and young people aged 10 to 24. So that's quite a significant amount of HIV in our adolescents in Kenya. And according to UNAIDS, adolescence is the only age group in which death due to AIDS are not decreasing. According to UNAIDS, there are 7,000 HIV infections every week, and adolescent girls and young women are infected with HIV in Eastern and Southern Africa. So here, Kenya, my country, the whole region, we are affected. But sadly for my neighbor, South Africa, about 1/3 of these infections in young girls and young women is in South Africa. And we know that 2.1 million adolescents are living with HIV, and 80% of them live in sub-Saharan Africa. We've already heard about mental well-being. I will not belabor this, but we know that adolescents are particularly vulnerable to HIV infection. And because of HIV infection, there's high mortality, and there's also poor adherence because there are many other issues that affect our adolescents. So we must take care of the mental health needs of adolescents with HIV in Africa and other low and middle income countries. Where have we been? I'm over 40, so I know a bit about the journey which we have gone through in the past 40 years. The early days of the HIV epidemic were perplexing and terrifying. Some of you young ones, you cannot fathom what people went through. But I just want you to rewind your time to 2020 during COVID. That's exactly how we felt. We didn't know what this virus is. There was a lot of stigmatization. There was a lot of fear, like we experienced in COVID. So that's exactly what the world went through in the early days of the epidemic. So the messages against HIV then were fear-based. Do not have sex. When I started I grew up with a stepmom. So the day I started having my menses, I remember I said, my nini, which is young mother, when I'm passing urine, there's blood, So she took a wad of cotton wool and she says, here you are, put it so that you don't spoil your clothes. If you play with boys, you're going to become pregnant. I'm like, I'm going to become pregnant. So messaging is very important, yeah? So this is where we were at early days of the epidemic. We were saying, HIV, if you do this, you'll die. Use condoms. Do not have sex. Sex is pleasurable. Why shouldn't I have sex? So though we soon recognized that we're doing the wrong thing, our approach was often top-based. We used to say to adolescents, do this, do that, don't do this, don't do this. We now know that adolescents and young people are not passive recipients of information. They need to be active in their own health. So in the past 40 years, we've had a lot to learn. I can talk the whole day about biomedical interventions. I'll not do that. I think I've only got one slide. But we also learned that, and we've heard from Dr. Gichani and from the Minister of Health here, that engagement, education, and empowerment of adolescents is really important. And we've learned that over the past 40 years. Sociocultural competence. We need to have access to services. We need to reduce barriers, whether they are physical, whether they are political, whether they are geographic. We need to reduce barriers. And of course, intersectionality matters. Adolescence is not just a monolithic group. No, adolescents are different. We need to have tailored interventions. We often talk about differentiated service delivery and so forth, but tailoring interventions to suit the different groups. Innovations in approach. I was talking to a colleague here who used to be a researcher who is now in digital world. I can't do that, but I would like to do that. COVID taught us a lot that the world digital health works in adolescents, and I'm sure we are going to enjoy your talk. Yes, thank you. And then the role of advocacy. So over the past 40 years, we've come a long way in terms of HIV prevention interventions. This is the train of HIV interventions, and throughout the week, you're going to be hearing about some of these interventions. But like I said, I'm mainly into pre-exposure prophylaxis, where we talk about antiviral-based therapies. We'll hear a lot about the launch and the implementation of long-acting cabotegravir. There will be a talk about lenacapavir and other interventions looking at pre-exposure prophylaxis. In this meeting, I don't think we are going to talk a lot about passive immunization, but that's where the world is going towards in terms of HIV cure and HIV vaccine. And also close to my heart are multi-purpose prevention technologies. So as you look at this train of HIV prevention methods, I'm really excited to say over the past 15 years that I've been in this industry, I've contributed to some of these interventions so that our adolescents remain healthy. So now it's up to you, adolescents and young people here, to tell me, the researcher, how do we do this together? Yes, this is our product. So how are we going to do it? And I'm hoping that by Friday would have mapped the way forward. So we've heard about engaging, and I was like, oh my word, she's just stolen what I was going to say. I think the Minister of Health said that programs that work for youth must be youth-led, yes, and must be implemented by youth. So here I'll just talk about some of the successes that we've had in terms of engaging and empowering youths. I'll start with the CATS. These are the Pierre Jandiri CATS in Zimbabwe. These are community adolescent treatment supporters. You know, they are trained in Zimbabwe. And I think it's now been rolled across the world. We've got a friendship bench where if you are feeling low, you can just sit there and someone from the village or the community will come and talk to you. So this is the friendship bench, highly successful. Our CATS, Jandiri CATS, highly successful in terms of peer-led counseling. And also South Africa has had the Let's Talk program, talking about HIV prevention in young women. We know about IMARA, informed, motivated, aware, and responsible about AIDS. I didn't want to have AIDS on my slides, so I just said responsible adolescents and adults, where young women and their caregivers, their mothers, they are given tools in terms of how to prevent HIV, sexual reproductive health. We know about Sauti Yevana, I hope, Voice of the Youth from Tanzania, looking at mental health issues in adolescent people with HIV. So I'm not supposed to blow my own trumpet, but I'm highly, highly happy that as a discipline, we've done very well in terms of engaging the youth. What about we know that a lack of education and poverty, they increase the risk of HIV. There have been so many cash transfer programs. HP10 was 167 in South Africa, the Zomba cash transfer program in Malawi, whereby young girls aged 13 to 22 rather, they were given $10 a month to in and out of school girls. And what did this do? There was a 35% reduction in school dropout rates, 40% reduction in early marriages, reduction in HSV2, reduction in teen pregnancies, and reduction in HIV. Yes? So in my early days as a presenter, I was told never to talk about religion, sport, and politics in my presentation. But today I will deviate and talk about religion and adolescent sexual health, reproductive rights. And just to impress Zuzu here, I picked this where Zambia has developed a tool for religious leaders. Religious leaders, I'll come to this in my next slide, but most of our religious leaders are very prescriptory. They'll say, do this, you'll go to hell if you don't do this, and so forth and so forth. But they've now learned to be participatory, to be less dictatorial, and to be communicative, looking at this handbook. And they are helping adolescents at churches or at the mosque. We know that religious leaders usually have access to all people, from christening the young ones to burying the elderly, so we can harness. And we know that whether it's looking at the Bible or the Quran, we know that religious leaders can play, and they do play, a leading role in adolescent sexual health, reproductive rights. What about traditional leadership? We are very strong in tradition in Zimbabwe. Zimbabwe, we've got the Not in My Village campaign, where after our Ministry of Women Affairs realized that there were so many early pregnancies, the local leadership, they set up the Not in My Village. You youngsters would say, not in my hood, yeah? But us will say, not in my village. So they looked at, how can we prevent HIV? How can we prevent teenage pregnancies? So this is highly, highly, highly successful, and well done to the leaders in Mashonaland Central. So despite these successes over the past 40 years, our young ones continue to face challenges: teenage pregnancies, HIV, other STIs, HPV. We'll hear about cervical cancer this week, non-communicable diseases. Dr. Chandiwana will talk about NCDs, obesity. Yes. So the worrying thing is between 2019 and 2022, a survey, a national assessment was done on adolescent pregnancies in Zimbabwe between 2019 and 2022. And during this time, there were about 1,700,000 pregnancies that were registered across 1,600 healthcare facilities. And what we got from here is that 21% of the bookings of the antenatal bookings were among adolescents aged 10 to 19. And a total of 1,500 maternal deaths were recorded, and amongst these, a whopping 25% were among young women. So this is a highly saddening statistics. And 31% of the young women reported that the first sexual encounter was forced. In 16 years, we are just a year older than the Kenyans. Our sexual debut was at 16, though I think it's now low. And the adolescent pregnancy prevalence rate was 28%. And we all know that economic decline and poverty are key drivers. So meet here, forget Nyamkadenga. She's from Mount Darwin in Zimbabwe. She became pregnant at 17 while she was doing her last year of high school. And she was forced to go and live with her husband because their parents chased her away. She had to drop out of school. He abused her. He took her cell phone so that she could not communicate. He had sex with her against their will and so forth. She lived a terrible life, but she's bounced back. This is one of our success stories. So what she says is that some of the things we do as young people is because we lack guidance and knowledge. So I just want to look at Kenyan adolescent and young people here. We see that in various, I think these are counties, correct me, I hope they are counties. There is low knowledge of HIV prevention. You can see it's coming as low as 10%, maybe other counties as high, like Kisi, as high as 60%. Well done to those counties. But there's very low knowledge of HIV prevention. We had the same from Zimbabwe, and there's high levels of teenage pregnancies. STIs. I've just picked South Africa. There are so many STIs. The same is happening in Zimbabwe. The same is happening in Kenya, Zambia, Malawi, Cameroon. There's so much Neisseria, gonorrhea, chlamydia, trichomonas vaginalis. I think I could present a lot on South Africa and Zimbabwe alone, but we've got so many STIs. Mental health, there's high prevalence of common mental health disorders amongst adolescents with HIV in Zimbabwe. This is a poster presented at AIDS 2024 from Impact 2016. About 2/3 of our adolescents in Zimbabwe living with HIV, they screened positive for at least one common mental health disorder. Same in Kenya here from the Kenya Adolescent Health Survey. injuries are not to be left out. So we need strategies to improve the quality of sexual and reproductive health services. We need to improve access to these services. We need to continue thinking outside the box. I put this slide. Those are images of STIs. They are very nice to look at, but they are horrible. So close to my heart, I would like us to focus on multi-purpose prevention technologies for adolescents. Yes, and this is a a Venn diagram of comprehensive adolescent health package. We can continue adding on improving healthcare seeking behavior, advocacy, youth leadership. The circles can go on and on and on. Yes? So, what is my call to action? Our journey on adolescent sexual reproductive health rights is far from over. We must continue. Whether you're an adolescent, whether you're from the Ministry of Health, whether you're a researcher, we must continue to invest in research, build robust partnerships. We need to commit to a future where every adolescent, regardless of their background, has access to information. Ministry here of Health, they've already talked about together. Let us ensure that the next generation is not just surviving, but it is thriving. I'll go further, Honorable Ministry, to say not just thriving, but they need to be enjoying their childhood, their adolescence. So you'll see me here. I'm youthful, so please don't take pictures. So in conclusion, I'll say let's enjoy with our adolescents. This is me here at my clinic. So Zimbabweans, please feel free to dance to the... Oh, can we have more? So this is my last slide. So, yeah. Thank you. So you go. All right, so that was my last slide. So that video was taken at my clinic, adolescent girls, and so they said, Doc, we want to challenge you to, this is the, like Jerusalem in South Africa, there was a challenge during COVID, and there is an ongoing challenge in Zimbabwe where we talk about when you've sunk deep in love, what should you do? So I said, adolescents, you've sunk deep in love. Let's talk about how to have safe sex. So we danced to that song, and I'm sure my point was taken home. So thank you so much. Thank you.